medial degeneration, there are no true cysts formed in this process. So now that we know what's causing the aorta to weaken, let's see what happens as the aneurysm progresses. Starting with the abdominal ones. Turns out that most cases of AAA are asymptomatic. And if there are symptoms, such as abdominal, back, or flank pain, it's usually vague and attributed to other causes. Often, an asymptomatic patient is referred for AAA evaluation after a pulsatile abdominal mass is palpated on physical exam, represented by that pulsating walkie-talkie stuffed in his pants. AAAs will also sometimes be spotted incidentally on imaging obtained for some other reason. And hopefully, if it hides out for years undetected, it's eventually picked up on screening. In the US, a screening abdominal ultrasound should be performed on any male older than 65 with a history of smoking. So we've given our crotchety old nicotine-addicted commander our recurring ultrasound bullhorn. Like I said, the vast majority of AAAs are pretty benign, but that doesn't mean that it can't get serious. If it gets big enough, it can obstruct vessels that branch off the aorta, leading to bowel ischemia or limb claudication. Additionally, the turbulent flow in the aneurysmal sac creates ideal conditions for a few blood clots to form. A thrombus in the lumen of an abdominal aneurysm can embolize distally and cause acute limb ischemia. That's not all. The mass effect of a large aneurysm can even compress a ureter and cause hydronephrosis and postrenal kidney injury. By far, however, the worst presentation of AAA is when it ruptures. Remember that aneurysm isn't just sitting there. These things progressively dilate over time. And according to Dr. Laplace and his law, as the radius of the aorta increases, the wall tension from normal hemodynamic stress also increases, because tension equals pressure times radius. In simple terms, that just means that the more it dilates, the greater the wall stress. So it just keeps on wanting to dilate more and more. A vicious cycle, much like Val Kilmer's movie choices in the 2000s. Okay, calm down. I'll see your kiss kiss bang bang, but I'll raise you, Red Planet. That's what I thought. To remind you that the risk of rupture depends on the diameter of the aorta and increases as the aneurysm grows larger, we've put this fragile sign across the diameter of the rocket engine. Acute rupture of AAA is incredibly devastating. Since the abdominal aorta is retroperitoneal, there can be massive hemorrhage back there causing intense flank pain and shock. Just take a look at this crew member up on the flight deck. He embodies the characteristic triad of a ruptured AAA. You've got severe flank pain, a pulsatile abdominal mass on physical exam, and immediate progression to hypotension and shock. Even with emergency surgical intervention, the mortality rate remains as high as 50%. Management of AAAs depends on the size of the aneurysm, since larger ones are much more prone to rupture. Large AAAs are often repaired surgically with a stent or a vascular graft. For AAAs that aren't large enough to be worried about, management focuses on smoking cessation and blood pressure control to mitigate the risk factors for aneurysm growth and rupture. All right, that's about it for the abdominal aorta. Next, let's run through those thoracic ones one more time. Like AAAs, thoracic aortic aneurysms are most often asymptomatic or cause only mild, nonspecific symptoms, the most common being dull chest or abdominal pain. Once it's big enough to compress other mediastinal structures, however, you'll start to see some interesting signs and symptoms. If a thoracic aortic aneurysm grows large enough, it can directly compress the trachea, leading to coughing, wheezing, or dyspnea. Compression of the left recurrent laryngeal nerve, which hooks right around the aortic arch, if you recall, can lead to hoarseness of the voice. Yep, those two yellow air tubes represent the recurrent laryngeal nerves headed back up to the voice box. And yes, we made his mask look like a horse face. Just try to unsee that. The next one is pretty obvious, and that's dysphagia. The esophagus is right in front of all that bulgy happening in the aorta. These symptoms can be downright irritating, but just like with AAAs, there are consequences of thoracic aortic aneurysms that are much more worrisome: cardiac disease, stroke, and rupture. Thoracic aortic aneurysms can cause a number of different cardiac complications. First, if the aneurysm extends to the aortic root, widening of the aortic annulus can cause aortic valve regurgitation. Just look at all that regurg. In fact, a considerable number of patients with TAA are diagnosed incidentally on an echocardiogram originally performed to evaluate a murmur heard on physical exam. Also, you may remember from the cardiac videos, untreated aortic regurgitation will eventually lead to heart failure. It gets worse. An aneurysm of the proximal aorta can actually cause impingement of the coronary vessels, leading to ischemic heart disease. This is symbolized by the Purple Heart Award, a purple ischemic heart. And to top it all off, the altered blood flow within the aneurysm can lead to thrombus formation. Just like in AAA, an aneurysm that involves the thoracic aorta proximal to the takeoff of the carotids can send emboli into the cerebral circulation, as a matter of fact, causing stroke. While both of these scenarios are bad, the most feared complication is rupture. As with AAA, the risk of rupture of a thoracic aneurysm is dependent on its size. Aneurysms less than 5 centimeters in diameter virtually never rupture. On the other hand, those greater than 6 centimeters have around a 10% chance of rupture per year. What? The classic description of a ruptured thoracic aneurysm is a patient with long-standing hypertension presenting with acute onset of sharp chest pain or upper back pain. Massive hemorrhage can result, leading to hypovolemic shock, or all that blood can fill the pericardium, resulting in acute cardiac tamponade. In either case, not a good day at work. Even with emergent interventions, survival rates are less than fantastic. Management of a non-ruptured TAA is very similar to that for a AAA. Larger aneurysms that are more prone to rupture are typically surgically repaired with a stent or graft, while smaller TAAs are generally managed conservatively with aggressive control of blood pressure and atherosclerotic disease. All right, before we wrap this thing up, I want to quickly mention a few inflammatory and infective conditions that can also lead to aneurysm. See those bacterial light signals held by the landing officer? In the setting of bacteremia, infection can take root in a damaged vessel wall. Maybe it's injured from IV drug use or a hospital procedure. Maybe there's an athromatous plaque smoldering away. Or maybe there's already an aneurysm there. These are all perfect conditions for bacteria to infiltrate, weaken the wall even further, and cause an aneurysm to develop or get worse. The term mycotic aneurysm is often used to describe a similar process that can occur in the setting of endocarditis, when septic emboli from the heart seed in the arterial wall, causing or worsening an aneurysm. A wide range of inflammatory syndromes, including large vessel vasculitis, rheumatoid arthritis, and ankylosing spondylitis, are associated with aneurysm development, especially in the thoracic aorta. Giant cell arteritis is the most common culprit, causing thoracic aneurysms or dissection in over 10% of cases. And last but not least, syphilis. Tertiary syphilis, to be exact. At one point, syphilis was the most common cause of thoracic aortic aneurysms, accounting for about 10% of all cardiovascular deaths. When was that, you ask? Before the discovery of penicillin in 1928. Today, not so much. Though syphilis remains an important health concern with millions of cases occurring each year worldwide. Syphilis is caused by Treponema pallidum, a spirochete, hence the spiral contrail left behind by the jet. See those nasty red vines around that sickly-looking aortic arch tree? Treponema pallidum has a predilection for infecting and destroying the vasovasorum of the thoracic aorta, leading to medial wall necrosis, a condition also known as obliterative endarteritis. As the spirochetes invade the vasovasorum, it undergoes hyperplastic thickening, restricting blood flow and causing ischemia of the outer 2/3 of the aortic wall. Starved for oxygen and nutrients, elastic fibers become patchy and smooth muscle cells die, causing expansion and aneurysm formation. On gross pathology, extensive fibrosis of the aorta gives it a characteristic tree bark appearance. On histology, you'll see an intense inflammatory response in the affected areas of the aorta, complete with a plasma cell-rich infiltrate, all those little blue nuclei. To diagnose it, look for linear calcifications on chest X-ray in a patient with symptoms and signs of advanced syphilis, all of which are covered in sketchy micro. Treatment? Penicillin. All right, that's it for flight school. Consider yourself graduated. But before we go, let's briefly sum up everything we've learned. Aortic aneurysms are true aneurysms, which is why we've included all the vessel wall layers on the landing strip. Abdominal aortic aneurysms, or AAAs as they're called, like to form in the infrarenal aorta especially. The risk factors for AAA development overlap with the risk factors for atherosclerosis and include smoking, male sex, and age over 60. Thoracic aneurysms are less common and like to form in the proximal aortic arch. The risk factors for thoracic aneurysms are also related to the risk factors for atherosclerosis, an important one being hypertension. Genes also play a role in thoracic aneurysm formation. A few genetic conditions to keep in mind are Marfan syndrome, bicuspid aortic valve, and Turner syndrome. Take a look at the weakened aortic wall under the microscope, and you'll likely see the classic signs of cystic medial degeneration, including an inflammatory infiltrate, fragmented elastic lamina, and smooth muscle cell apoptosis and necrosis, all occurring in that vessel media. The bigger the AAA, the more prone it is to rupture. Watch out for that pulsatile abdominal mass, flank pain, and progression to hypotension and shock. Thoracic aneurysms, if they get big enough, can compress surrounding structures and cause some serious regurg at the mitral valve. It can even impinge on those coronaries. Both abdominal and thoracic aneurysms like to hide thrombi and cause embolic strokes. Really big thoracic aneurysms also like to rupture. By really big, we're talking over 6 centimeters, by the way. Massive hemorrhage can lead to tamponade, hypotension, and shock. And that's all she wrote. For part 2, let's head below deck, because we've got even more vessel wall problems. This time, instead of a full-on rupture, blood is going to start dissecting apart the vessel wall. It's as bad as it sounds. To the engine room!